I think we're ready to get started. John Hammer, you want to
Yes, indeed. I would
give us the invocation?
welcome everybody. We're delighted you're here. This is the fourth in a series that we've been hosting. We're partnered with other institutions, and it's a broad-based effort to try to bring a debate to America during a presidential election that seems to be remarkably substance-free. I mean, we've got lots of anger in the room, but we don't have a lot of conversation knowledge, and that's what we're trying to supplant. And we want to say thank you to all of you for being a part of that, for making it possible for us to do this. As you will see, this is a slightly modified version of something familiar in Washington, which is a congressional hearing. And we do have members of Congress who are going to be here, and they're going to be participating in dialogue with witnesses to talk about the crucial issues that we face in this country. I want to say a very sincere thank you to these former members of Congress that still feel compelled by the urgency of the day to take this important role. None of them, finds this a premier thing to do with their time, but they think it's urgent for the country's well-being, and I want to say thank you to all of you. Senator Nunn, let me turn it over to you, and we'll get this started. Thank you.
Okay, John, thank you very much. We welcome everyone here to the fourth, as John said, forum. We call it Strengthening of America, Children's Future. So thank you, John, to you and the entire CSIS team, including particularly Craig Cohen, Andrew Swartz, Ryan Sickles, for hosting us and doing so much to make these forums a success. I also want to thank Bob Bixby, who heads the Concord Coalition, Jeff Thibert, and other valuable members of the Concord team who have made this effort possible. Steve Bell, Pete Domenici and Steve have worked together for many years, and Steve is at the Bipartisan Policy Center and has been a big part of this, and Valeria McPhail on my staff, who reminds me every day that she is the only female keeping all of these males straight in terms of the staff effort right now.
Only takes one.
That's right. This is an effort of a number of organizations who have a variety of perspectives, but the common denominator is that all of us believe that America's current fiscal course is both irresponsible, unsustainable, and dangerous. These organizations include the Concord Coalition, the Center for Strategic and International Studies, the Bipartisan Policy Center, the American Business Conference, the James A. Baker III Institute of Public Policy at Rice University, the Belfer Center at Harvard University, the Hoover Institute at Stanford University, including John Taylor, who is one of our distinguished panelists here today, and the Woodrow Wilson International Center for Scholars, Jane Harmon, who has been in two of our hearings, and former CBO Director Rudy Penner of the Urban Institute has also been a key advisor. And I see John and Dean here from the American Business Conference. John, thank you, and Al West and all who have helped us here. These forums are part of a larger effort with many allies. We're working in full cooperation with the Campaign to Fix the Debt, chaired by former New Hampshire Senator Judd Gregg and former Pennsylvania Governor Ed Rendell, and led by the Committee for Responsible Federal Budget's President Maya McGinnis. We're also working closely in this quest for fiscal sanity with David Walker's Come Back America initiative and the Peter G. Peterson Foundation's ongoing and invaluable effort to call attention to the fiscal challenges that threaten our nation's future. Particularly thanks to Pete Peterson and Michael and the Peterson Foundation for their financial support, without which we would not be able to pay our bills. So we're very grateful for that. Pete Domenici and I are co-chairing these forums with our colleagues Warren Rudman and Evan Bayh. Evan has joined us today. Warren could not be with us. We've assembled a bipartisan group of 35 former members of the Senate and House who've signed on to this initiative and whose names you can see in your program. Pete and Evan and I are honored to have with us today former Senators Bill Brock and Byron Dorgan and former Representative Bill Frenzel. We've come together in the heat of an election campaign because of our growing concern that our nation's perilous fiscal position and our growing frustration with the seeming inability of Democrats and Republicans to work together to find solutions. Both sides seem to have a political strategy, not much doubt about that, but their governing strategy is in doubt to say the least. If this doesn't change, our fiscal woes will deepen, public cynicism will fester, and financial markets will grow increasingly alarmed. As we should have learned by now from Europe, markets are comfortable until suddenly they are not, a point made very clearly by two of our first witnesses in the first forum, Bob Rudman and Jim Baker. Previous forums have examined the financial, the international, and the national security implications of our nation's troubling fiscal outlook, the opportunity for pro-growth tax reform, and the potential for bipartisan solutions. In these forums, we've heard from distinguished speakers such as James Baker, Robert Rubin, Robert Gates, Michael Mullen, Erskine Bowles, Alan Simpson, Marty Feldstein, Larry Summers, Alice Rivlin, and of course my co-chair, Pete Domenici. He and Alice chaired a parallel commission, very important effort to Simpson Bowles. Our focus today is health care and entitlement reform. At today's forum, we will hear from Alice Rivlin of the Brookings Institute, making her second appearance, which Alice demonstrates both your great wisdom and your high threshold for pain. We appreciate you being here for both, as well as John Taylor of the Hoover Institute. They'll be on our second panel, as well as our first panel, former HHS Secretary Donna Shalala and former Senate Majority Leader Bill Frist. There are many parts of the puzzle that must fit together to solve our problems and to get us on a sound course, including tax reform, streamlining our military budget while maintaining our strength and encouraging strong, sustainable economic growth. Congress and the executive branch must also, over the short term, medium term, and long term, do a much better job of oversight, keeping track of which programs, including tax preferences, work and weeding out those that do not. No task, however, is as important as gaining control of the rapid growth of our major entitlement programs, including the three largest ones, Medicare, Medicaid, and Social Security. The projected growth of these three programs, which run on autopilot, accounts for the entire projected increase of federal spending as a share of the economy over the coming decades, excluding interest on the debt. And Pete Domenici has a chart which he may use again today to demonstrate that pretty clearly. Let me just make a couple of observations before we turn it over to Pete and our fellow panelists, as well as the people who will be enlightening us today, Donna and Bill Frist. First, these programs we're talking about that are growing so rapidly are very successful and very important programs. They have vastly improved the standard of living among the elderly and disabled in our country. Dismantling these programs is simply not on the agenda. Second, regardless of how successful these programs have been, they are not on a sound financial footing for the future. In the case of Social Security and Medicare, promised benefits far exceed dedicated sources of income from the payroll tax and beneficiary premiums. Over the next 25 years, the annual cost of Social Security and the major health care entitlements are projected to grow by about 6% of the gross domestic product, caused in large part by the blessing of increased life expectancy, but also by increased medical costs per capita. At some point, our nation must recognize that programs that were created when the average life expectancy was 65 must be adjusted when life expectancy moves to 80. That is why entitlement reform is the central fiscal challenge. During these forums, we have, I think, clearly demonstrated the magnitude of the fiscal challenge, why the American people should care about it, and why both political parties have to work together to solve it. Today is the last forum for the time being, but certainly not the end of our activities. We will issue a report on these programs in the next few weeks, and we will be active in the policy debate when the election season ends and the governing session begins. I remain optimistic. In the end, I believe that all Americans, regardless of political affiliation, will recognize that this is not just about numbers, it's a moral and generational issue and challenge. I remain optimistic. Winston Churchill famously said, "America will always do the right thing after we have tried every other alternative." Fiscally, I hope that we're nearing the end of Churchill's prophecy. So Pete, with that, I'll turn the mic over to you.
Well, thank you very much, Sam, to our fellow members of Congress who are with us today. Thank you so much for coming today and for your support in the past. In particular, Evan Bayh, you have not been unable to be with us, but you've been with us as we put this event together. Thank you for that. Let me say, Senator Nunn, that I want to emphasize how critical the subject that I'm going to talk about is to both federal and state and fiscal challenges, and most importantly to the American economy. We have one chart with us. It seems to sum it up for me and for the federal fiscal level. We can see the chart before you. Everyone take a look. This is an easy one to remember the problem of your country by calling it the blue line. Some people think that based upon their memory of things and the feeling of things, the blue line is something very healthy, very satisfiable. It's the kind of thing you want to do. Well, in this case, you see the blue line wins. But the problem is that it's winning so much that it loses. We lose, the government, the United States, not the government, the United States loses because as this one chart sums it up, this is what's happening to the government, United States government health care costs. Up, up, and away. While the other four basic programs of our national government, Social Security, discretionary spending, you can see them there, they're all controllable, but not the health care cost. It's just gone up, up, and away. The health care spending rises dramatically, and the Bipartisan Policy Center recent report, which was authored by Senators Frist, Daschle, myself, notes that several factors are driving this. Sam has alluded to them. I would summarize them. First, healthcare inflation. Although subdued the past few years, there's no doubt that it will reaccelerate as the onslaught of retiring baby boomers further age and increase their utilization of the healthcare services. Secondly, baby boomers demographic means that we are adding about 10,000 Americans each day to Medicare, 10,000 each day. It is estimated that 52% of the spending growth in the federal health care programs over the 2 decades will be due to this demographic tsunami. Did you get it? Obviously, it's a big, big event. So we face a double whammy. More seniors, which we're thrilled about, more costly medical care for each senior, and we did not count on either as we told these people what they would be getting from their government, these wonderful senior citizens. We don't have to hurt them or harm them, but we must reform the program so that the blue line, best way I can put it, is if that blue line that you see can be broken, and instead of continuing up, if you can make it where it turns a bit, and even if it's 10 years out when it starts to turn, but it's real, then you have begun to solve this problem. You must break that curve, which is upward, and turn it downward. The escalating costs are not confined just to federal programs. Each and every American faces the reality of health care cost increases, and they affect various plans which you no longer can continue, which no longer will work, just like the federal government's programs that we have before us. The increasing of public costs transverse into the private sector, hurt businesses, hurt competitiveness, and potential employment. Now, finding a way to finance our healthcare system is urgent and necessary. We've got to bend the healthcare cost curve, as I indicated. We need healthcare and economic policy leaders to work together. They can't be off talking aside, talking on some way to solve something that the other's not looking at. The Bipartisan Policy Center study that I mentioned has begun to look at alternative policies that might contain the growth of healthcare spending in this country. There is a program, there is a proposal, but we're looking at more and better ones to see if we can have more to offer as Congress in the not-too-distant future, hopefully, begins to try to solve this problem. We've made promises as elected officials to Medicare and Medicaid, to military retirees and others. We cannot keep those promises without reforming tax and program policies that impact the healthcare sector. We hope our healthcare cost containment initiative will inform needed policies and policy changes that will benefit both the public and the private health care sector in addressing these escalating costs. So, Mr. Chairman, it's been my privilege to work on this. I'm hoping that from it, those who must solve our country's problems in the not-too-distant future will understand that the list of organizations that you, as our co-chairman, announced when you were talking about who's with us, when the list grows by the day. If they find out, if there are groups in America that find out this is going on, they want to join. Why is it that everybody tells us this has to be done? Why is it that so many groups that represent America's interests and have millions of members, why is it that they want to join in fixing it, and yet we continue to wait, not knowing when the axe will fall, but knowing from our experts that it would not be a good day for America if, in fact, our sovereign dollar was truly put in jeopardy. That could indeed happen. Thank you very much.
Thank you very much, Pete. Evan, do you have any observations here?
Well, just a couple, Sam. First, to you and Pete, I want to thank you for your leadership. I wish Warren all the best. He's been a good friend. I say it's an honor to be here with our panelists today. Senator Frist, for a period of years, was the leader of the other political party, but he's still my friend and someone I could work with, and was always a voice for reason. So, Bill, it's great to be with you again here today. I first met Donna Shalala when I was a humble governor from my state of Indiana, and she was the Secretary of Education and just performed outstandingly in that capacity. And I've admired from a distance, Donna, the work you've been doing at the University of Miami. As a matter of fact, I think I can say I agree with Donna Shalala on almost everything, with the possible exception of who we'll be rooting for in the Miami-Notre Dame game this weekend. So forgive me for that, but football loyalties are parochial. And all of you, I want to thank you for being here, because ultimately this is going to be a job for the American people. As Harry Truman once famously said, in the United States, it's not the politicians who run the country. In the United States, it's the people. The politicians, we're just a hired help. So it's important through forums like this to get out the word about the importance of tackling this issue and to educate the American people about the best way to go about it. Promoting economic growth, first and foremost, is something that would do wonders to solve our fiscal problems. Secondly, looking intelligently at the tax base, how to organize that efficiently to promote investment, job creation, and also pay for our national defense, servicing the debt and the other things, the other obligations we have to meet. And finally, the issue of spending. As the lines that Pete was referring to show, domestic discretionary spending is pretty much under control. Military spending will be coming down as a consequence of unwinding the conflicts in Iraq and Afghanistan. Social Security is politically very difficult, sometimes referred to as the third rail of American politics, but not conceptually that hard. And I would anticipate that that would be among the things that will be recommended. The hardest part is the topic for our panels today, and that's what to do about that blue line that Pete referred to that is just going up, part of which is to be expected and not altogether a bad thing. Our population is aging, as my colleagues have pointed out. There are advancements in medical technology and treating people. That's a good thing. But it can't continue to go 2 or 3 times the rate of inflation as far as that line extends without eventually gobbling everything else up. Oh, and by the way, some of the most obvious areas of savings have already been utilized for other initiatives our government has recently adopted, making the challenge even more difficult. So we're really here today the final thing I'd say, Sam, is just to conclude by saying I think it's a Chinese proverb that says the real test of statesmanship is someone who plants a tree in whose shade they will never rest. many of the solutions we're here today to discuss and hopefully put into place will only bear fruit 10, 20, 30 years from now. But in so doing, we'll strengthen our country and enrich our children's lives. And to me, that is a true test of statesmanship. And Sam and Pete, I want to thank you for meeting that test today.
Thank you very much, Evan. We appreciate your being part of this group from the very beginning and your leadership. Bill Brock, and have any opening comments?
Maybe less than a minute. When Evan and others talk about the American people being the boss, they have to know what the problem is. There's nobody telling them. There's no serious debate at the national level about debt, and it's eating us up. And if you look at the solutions, if in fact entitlements are taking every single dollar of federal revenue every year, entitlements take it all. What's left are all the discretionary. Federal employees, national security, health, education, all of those have to be funded by debt. So anybody that tells you we can cut our way to stability, I started to say maybe smoking something strange, but it's irresponsible. If you look at the alternative and say, maybe we can solve this by taxes. To solve it by taxes, you'd have to raise taxes 50% on every living American. It's irresponsible to say we can solve it by taxes. All of this has to be part of a whole. Everybody's going to have to take a piece of the pain. Somebody has to tell us the truth. That's, I hope, what we can contribute to, because if we don't kickstart this campaign into telling the American people the problem, they're not going to know. And when we try to solve it next year, they're going to be screaming, oh, you didn't tell us that. Well, we didn't. And that's our fault.
Sam, can I correct something I just said? I don't want people to think I'm completely senile yet. I was thinking about Donna's tenure at Miami, and previous to that at Wisconsin. Of course, she was Secretary of HHS, not Secretary of Education, Donna. So you'd make a great Secretary of Education, by the way. But maybe that's your next career.
Thank you, Evan. Byron?
Sam, thank you very much. I'll take only 1 minute. You have, I think, and Evan quoted a Chinese proverb, and Churchill, let me quote Garrison Keillor, who said, "We were raised by people who taught us that life is an enormous struggle. And if at some point you should feel really happy, be patient, it'll pass." And it reminds me kind of the somber mood of this subject. To solve this will be painful. Not to solve it will be very painful and very destructive to this country's economic future. It is not overstating it at all to say that our economic future is now at stake. So thank you, Sam and Pete and the rest of you who have convened this as well.
Thank you. Bill?
Thank you, Mr. Chairman. Thanks to everybody. I look forward to hearing from these great witnesses.
Okay, let me give a very brief introduction of both of our witnesses, and both of them have had so many achievements I could go on forever, but I will make it very abbreviated. Dr. Donna Shalala became Professor of Political Science and President of the University of Miami on June 1 of 2001, has had more than 30 years of experience as an accomplished scholar, teacher, and administrator. In 1993, President Bill Clinton appointed Donna U.S. Secretary of Health and Human Services, HHS, where she served for 8 years, becoming the longest-serving HHS Secretary in U.S. history. At the end of her tenure as HHS Secretary, the Washington Post described her as, quote, one of the most successful governmental managers of modern times, end quote. President Shalala has more than 4 honorary degrees and a host of other honors. In 2008, President Bush presented her with the Presidential Medal of Freedom, the nation's highest civilian award, and in 2010, she also received the Nelson Mandela Award for Health and Human Rights. Donna, we're delighted to have you. And let me give Bill a brief introduction, and we'll go from Donna to Bill with our statements. Bill Frist, as both a nationally recognized heart and lung transplant surgeon and former U.S. Senate Majority Leader, Senator and Dr. Bill Frist is uniquely qualified to join us today to discuss health care policy issues such as cost control. At the Bipartisan Policy Center, Senator Frist, along with Senator Tom Daschle and Pete Domenici and Dr. Alice Rivlin, leads the Healthcare Cost Containment Initiative, which will be seeking approaches to contain healthcare cost growth on a system-wide basis while enhancing healthcare quality and value. Senator Frist represented Tennessee in the U.S. Senate for 12 years, where he served on both Health and Finance committees responsible for writing health legislation. He was elected Majority Leader of the Senate in 2003. Dr. Frist's latest book, A Heart to Serve, The Passion to Bring Health, Hope, and Healing, discusses how his family shaped his values, his arduous path to leadership and service to others through heart transplantation, his jump to serving a larger community through the political world, and his commitment to global health and communities around the world. Bill Frist is continuing to be fully focused and fully engaged and dedicated to the many important facets, challenges, and opportunities of our healthcare field, as well as many other fields. So, Bill, we're delighted to have you and Donna. Pete, you want to say a word?
Well, if I didn't say a word about Bill, he would wonder if I had changed my mind and decided that I didn't care a lot about him anymore. That would be a terrible thing. So I just want to say, Sam and fellow members, I remember, you know, I remind you often that I'm kind of losing my memory a bit, but this one, I don't know why I remember it, but he was standing on the floor of the Senate, and he looked like he wanted to go somewhere, and I said, where are you going, Bill? And he said, I'm going to the White House. I said, now? It's middle of the afternoon? Yeah, he said, somebody else is going to manage here. Nothing much going on. I'm going to the White House. What for? I said, I'm going to see the president. What for? He said, I'm going to talk about the President of the United States supporting the largest program to save human lives that has ever been initiated. And I said, you are? Yes. Well, I learned shortly afterwards that afternoon yielded the program that our then president initiated for the HIV treatment, where there was a new breakthrough, and the only country that could afford to pay for it and save millions of lives was the United States of America, and the president was President Bush. And that afternoon, he started the talk, which ended up with that program being adopted. I thought maybe everybody ought to know, in spite of the thing, in addition to the things Sam talked about, he did just little things like causing the United States of America to do what I just described. He does things like that kind of on a timely and a manner that many of us don't quite understand, but he sure gets them done. Thanks, Sam. Thank you, Bill.
Pete. Thank you both for being here. Donna, we'll let you lead off if that's okay.
Thank you, and I said we're going to be very. Of course, it's an honor to be here with all of you. I was very wary of coming with an election going on, but Alice Rivlin prevailed on me, as she often has. I run $1 billion plus academic health system, so I spend most of my time down in the weeds of healthcare, not in the broader policy issues. So I thought this would be fun to deal with some of the broader issues. Budget experts, though, here in D.C. Can do all the analysis that they want, but as you have carefully pointed out, each of you, you'll not achieve what we all want if we don't integrate the health policy much better in the political community into whatever our discussions are. This is a different beast than that some of the other areas for discussion. And I worry about the public. They continue to react very negatively to what they perceive as budget-driven set of reforms, particularly to the healthcare system. They don't trust Washington. They don't think Medicare is the reason for the deficit. No matter how much we talk to them about the driving cost of healthcare, they're very wary of everything that we've been proposing. And interestingly, for now, Medicare is growing at below GDP per capita growth rates, and as such, early year cuts will be very hard to come by. This is not to say that we don't need to do significantly more and to really get our house in order for the next 10 to 20 years. But we have to be careful of front-loaded, excessively large, poorly designed, budget-driven health policy, which has the potential to hurt the economy and patients and undermine our real desire to reform a much needed to be reformed healthcare delivery system. And more than anything, I do believe the healthcare system needs to be reformed. The bipartisan policy report and the 13 major cost containment recommendations are very significant because it's one of the first times that they've been summarized together. But each of those recommendations have their own politics. In fact, I teach the politics of healthcare, and each of those recommendations, I could do my 50-minute lecture on the stakeholders and the very complicated politics that surround each one of those. So as we work our way through, we have to be both careful and, I think, courageous. The challenges are, of course, the discussion now. Whether they're caps or whether they're a panel, those are fallback positions from my point of view. They're fallback positions that I hope will force Congress to have a serious discussion about what we can do in healthcare to try to contain costs over a very long time, and in the process, make the delivery of healthcare more seamless, of higher quality, with much better outcomes. That's the point. We want a better healthcare system at the end of the day, not a weaker healthcare system at the end of the day. We spend a lot of money on healthcare, and we know that. But it can't just be the federal government, and it can't just be Congress. As your own reports point out, the states have a significant role here. I just finished chairing for the Institute of Medicine a report on the future of nursing. The fact is, there are serious state restraints in this country, as the report pointed out, on healthcare providers. They invest significantly in training nurses, physician's assistants, and other professionals, pharmacists, and then don't let them work up to their training level. They restrain what they can do in the healthcare system. Unless we see healthcare as a team sport, we're not going to get this job done. So without going through all the cost sharing or the value-oriented benefit designs that both Bill and I can discuss, let me make one final point. And actually, Senator, you gave me the opening. The great running backs at Notre Dame and at the University of Miami are patient. They wait until the holes open up. That also describes the political system when it's most successful in the United States. It sees the holes and it makes the holes. And we have to take advantage of what is an opportunity of a lifetime to reform the healthcare system over a period of time, but make sure that all the stakeholders are at the table with us in the redesign of a system that needs to fundamentally be redesigned, whether it's eliminating fee-for-service or allowing healthcare providers to work together as teams, or controlling the costs of chronic illness, or eliminating the very heavy costs that all of us bear at the end of life, while not diminishing or reducing the values that we have in this country. Thank you very much.
Thank you very much, Donna. Bill?
Thank you. It's great to be with everybody and to be back in town here. And I hope over the next few minutes it can reflect in the question and discussion a little bit about what the real world is like. And I say that part in jest, but I think it is a very important issue because much of the discussion here misses the dynamic of how healthcare is actually delivered. And Donna mentioned that she is in essence on the front line, sort of in the weeds. But unless you are there, which most of Washington is not, the real magic of what a doctor-patient relationship or a nurse-patient relationship is all about. The integration of being able to respond with science, but do it in a way of artistry and understanding of how you change behavior, which is a cultural element, which it's hard to get to when you're looking just at budgetary issues. The importance of innovation, and I look at my own world where I've done hundreds of heart and lung transplants. I've used artificial hearts. I've used lasers. I've done thousands of operations. I've written 20,000 prescriptions over time. All of that never gets really reflected in the discussions here, and it really did not in the development of the Affordable Care Act. And I, obviously I'm exaggerating a little bit, but to me the genius of what we're going to have to address, which Washington probably isn't going to want to, we'll approach it from the budget end because we got to, but Washington, and you see it play out in the presidential races, in all likelihood, they're not going to want to come back and address the macro healthcare issues. The federal outlays that we just looked at, and the focus will be on Medicare for good reason, but that's a $550 billion program of a $2.5 trillion healthcare system that has this genius and magic and dynamism and artistry that affects all of us in a very intimate way. And you really can't dissociate them. And that's why we can't look at it just as a budgetary issue, which from the greatness of America, which depends on the debt, which depends on the annual deficits, which depends on entitlements, and the only entitlement that really matters, if you really look at what's underlying the chart that Pete showed, is Medicare, the one that's going to be increasing over the next 75 years, and that depends on the value equation. And the value equation in its numerator has outcomes, has results, has healing, has health, has prevention, but in the denominator is the dollar sign, per dollar invested. And the Affordable Care Act did not do that. We can put all the demonstration projects. It didn't. It's an insurance bill. It's an access bill. It's a fairness bill. It's an equity bill. It is a moral imperative bill, and that's good stuff. And it's important stuff, but the central organizing principle of that bill did not focus on cost, did not focus on the denominator of the equation itself, and yet that's what we have to do. To march out greatness of America, entitlements, deficit, debt, deficit, entitlement. Medicare is where the action is, and I just hope that we can address it. The budgetary approach to it is a good one, and it really comes down to what what Senator Domenici said. We have a doubling of the number of seniors coming in over the next 25 years. So we got more people that we got to take care of. The per capita cost is going up. It's going up for all the people in healthcare, we know, but that particular group is going up because of chronic diseases. Most of them have. And almost everybody will have, 99% will have some sort of chronic disease, so that population is aggravated. So you got twice as many. The per capita cost is going up, and we'll come back to that in discussion. And then what Pete did mention is that we have fewer people paying in. We just don't have, we used to have 5 to 1 and 4 to 1 and 3 to 1 workers paying in. So the equation does not work. So then we have to decide how to fix it, because it has to be fixed. And the fixing it can't just be caps. It can't just be GDP plus 0.5%, 1%. It's going to be part of it. But the organic part of it, the system delivery, where the technology and the innovation and the prevention and giving birth and disability and fighting autism and Alzheimer's is exploding and obesity, which is tripling our costs, which wasn't a problem 3, all that's got to be addressed, and it has to be done through delivery systems and the preservation of innovation and creativity and delivery. America has been great, and we're proud of it, and I love it. I was in London 2 days ago, and I just love comparing America to anywhere in the world in terms of innovation. And the innovation itself has been in medical imaging with the MRIs and PET scans. It's been in my artificial hearts. It's been, nobody done lung transplants when I started my training. And then I ended up doing them routinely every week. I mean, it's unbelievable. All of that innovation we do need to protect over time, but it does cost money as we go forward. So we have to be careful to protect it. Washington said, well, we put $50 billion in NIH. That's good. But $70 to $80 billion comes out of the big bad pharmaceutical companies and the big bad device companies. Let's just tax some more. $70 to $80 billion of research, much more than NIH comes there. And another $20 billion comes out of universities and private foundations and the like. And it's the integration of these models that we've got to protect over time. let me just close off because the BPC, the Bipartisan Policy Committee, put out a good primer that the staff put together. And since our conversation has to center around cost overall, on Medicare, yes, but Medicare cannot be dissociated from the macro sense of what those healthcare costs and drivers are. The easiest way to look at it is the simple equation of cost. And you can put spending. Cost and spending are not the same thing. We'll probably call them the same thing. But cost and spending equals the population, doubling of the number of the seniors over the next 30 years. And then a lot of people stop there because they say, well, you can't do anything about that. Well, of course you can. Obviously, you can raise the retirement age. That does affect the larger macro issue of health care. If you're not going to be covering people at age 65, you're going to move it up. But also, the population part of that equation you can look at in terms of maybe not focusing on all of them. Maybe do a little more means testing like we did in the Medicare Modernization Act. Maybe focus on those with chronic disease and not the chronic disease. So there's a lot you can do in the equation, but it's cost equals population plus unit service, how many services you do, times the cost of the service, and then you have to add administration. And that's the equation. Population, or cost equals population times number of services, cost of each of those services plus administration. And then you just have to go down each one of those and see how complex it is, but how you can't just put a single cap, or if you put a single cap, you're going to have to look at the intertwining of that relationship. And I hope that we'll have the opportunity to do that over the course of the next couple of hours and look at a number of those issues. But if you look at it in that way, you do exactly what Donna said. In the population, what do you do? Can we take care of everybody with the same level of care, or do you need to focus? You move over and you look at the services. Well, Washington basically says get rid of fee-for-service. That's good, but it's too simple. It's hard, but it's getting easier. But it's just too simple. You got
What are you talking about?
fee for service.
Yes.
When we're looking through the equation, people will say, if you get rid of fee for service and go to population health, all of which is very good, it will take up. But that's not what's necessarily driving the number of services. All of a sudden, as a doctor, I come in and I see somebody with prostate cancer, and I've got 6 different ways that can treat that, all driven by technology, unbelievable technology. The outcome is the same. But technology drives the number of services that I can offer in an individual coming in. The number of services driven by the American culture. I was in London 2 days ago, and I was talking to patients there, and they said, we just don't expect to have the very best all the time. And we don't expect to have chemotherapy at the end of life, but our American expectations, culture, well, that's not a medical system, a healthcare system. That's a change in culture. That's a change in behavior. We got to start thinking about Facebook and social networking, actually how you change culture itself. If you move over to the cost per service, that's number of services, to the cost per service, again, heart transplants just cost a lot of money. Putting seeds in the prostate just costs a lot of money today. And then, of course, if you move over to administration, people say that's easy to cut. And here people say medical loss ratio, that'll take care of it. That may be a good thing. That's, if we pay $1 down, 80% of it needs to go to the patient and 20% to administration and control that. But administration is also information technology. I'm a doctor. I see the government come in and say, I've got to use these computers. Instead of seeing 13 patients a day, I can only see 9 patients a day. It slows me down. It's much quicker for me to see a patient, write it down. And it's not just for a week or a month or a year. It may be 2 or 3 years that you're coming into my office with information technology that's good, that decreases my productivity. That's part of administrative cost. So it's too simplistic to say just medical loss ratio. Anyway, the cost issue is there. The equation is simple. It is the greatness of America that focuses on Medicare, and that's the significance, I think, of this discussion today.
Thank you, Bill. One of the things that's frustrating, I think, is to read that the other industrial countries basically spend a lot less per capita portion of GNP than we do. I had 2 questions on that. Number one, is that accurate in your view? And do they get better or worse results? Do we get better results for the amount we spend? Either of you.
Well, we have completely different systems. They spend, other countries of the world spend a lot less on pharmaceuticals, for example, because they negotiate for bigger populations, and they've been doing that for a very long period of time. It's been more central. We have a much more fragmented system. So we spend 2.3%, I think, more on pharmaceuticals than other countries. On other kinds of healthcare professionals, we do pay our people more. Our professionals make more money than other professionals in other countries. There's no question about that. They're either
And that's a
salaried,
good thing.
and that's our people
Our
consider
doctors
that a
get
very
paid
good
more
thing.
than any other
Our
country.
doctors
That's a good
certainly
thing.
get paid more than they do in other countries. Do they get better health outcomes? The evidence is yes, but some of that is because they have more homogeneous populations. So it's a tricky measure. But do other countries, most of the rest of the world has more centralized systems. They pay less for all of the services. They're more tough-minded about specialists and people getting to specialists. They put more money on the front end for primary care. So there are a number of explanations for why that takes place. And Bill has
Let me jump in because this is a great thing because the New York Times always opens with that. So I'm glad you opened with it. It's important. The United States of America spends twice as much per capita, either in absolute terms or as a percent of GDP, than any of the OECD, the other comparable countries on average. Spends twice as much. Our outcomes are much, much less, and therefore we need whatever you want to put, universal health care, socialized medicine, Nixon care, Clinton care, whatever. That's what it always says. We need more universal insurance. That's always what it is. So everybody should be thinking right now, well, how do you answer that? Is that right? To answer your question, number one, if you've got cancer, you want to go to nowhere else but the United States of America. And right now there's probably a 30% chance you're going to die of cancer. If you have heart disease, if you have significant heart disease, you're not going to want to go to any other country in America. If you have a heart attack right now or a stroke right now, you want to be in America today. And there's probably a 35% chance you're going to have a heart disease. But if you look at mortality and how long you're going to live, you don't want to be in the United States. You want to be in 26 other countries. And if you're going to have a baby, you don't want to be in the on average, you don't want to be in the United States. You want to go to 30 other countries to have that baby. So to answer your question, yes and no, but if you use how long you live, it's right. We spend twice as much. Our outcomes are much, much worse than the average on countries in infant mortality. So then you say, and this is probably the most important thing I'll say today, then you'll say, why? And Donna started to list them, but it's pretty easy actually. Take any endpoint you want. You can put cost in there, you can put how long you live, and you can put infant mortality. We're going to put how long you live because it's easy, and that's the one that the New York Times is quoting. What determines how long you live today? If you take 600 of the sort of macro studies out there and you put them together, and you can do the same thing globally, and you can do it here in the United States. How long you live, which is the outcome that you're referring to, is driven by what? Genetics. Human Genome Project, a very successful project, by the way, public-private partnership, finished on time, started in 1990. We finished it, $3 billion put in, return $1 invested, $147 out, unbelievable project. But genetics is about a 30% determination. Say 100% is your overall determination. Genetics is 30%. Socioeconomic, how rich you are, where you live, very important. 3 subway stops here from Washington, D.C. is a 12-year difference in how long you'll live. From where we're sitting right now, 3 subway stops, the difference in mortality, how long you live is 12 years. Something wrong. But as an independent variable, how rich you are is only about 15%. 30% genetics, 15% socioeconomic. The environment, the bigger environment, pollution and all, about 6% overall. The insurance, the Affordable Care Act, Nixon Care, Romney Care, all of that is only about 15%. Who your doctor is, what hospital you go to is only about 15% of how long you live. Pretty interesting, because the New York Times basically said, spend twice as much, outcomes so poor, therefore we need different insurance. Not where the action is. The action is 40% of how long you live is in behavior. And behavior is K through 12 education. Behavior is obesity. Behavior is wearing seatbelts. Behavior is whether or not you smoke. Thus, the opening paragraph is right, but if we're going to address how long you live or health care costs, What you need to do is address that 15% of hospitals, insurance, Affordable Care Act, all the other stuff, who your doctor is, where they train, do that. But you've got to look at the 40% change in behavior, and you got to link those two. And in policy, you got to link the two if you want to change outcome.
Yep.
And you can put everything else in there, and that's going to be the secret. Are we in Washington smart enough to have that overall 55% impact?
Well,
come in?
and what Bill's pointing out is there are things we can do in healthcare to get better outcomes that are low-tech, that are not high-tech. We put an enormous investment in high-tech, but there is a lot we could do. If we get people to exercise, eat right, and not to smoke, we'd have plenty of money to drive down that piece, and do the kinds of changes that we're suggesting in the healthcare system.
Thank you very much. Pete?
I don't know if the rest of you who are entitled to ask, I don't know if the rest of you who are entitled to ask questions are as confused as I am, but I've heard my great friend explain this, and I'm confounded. I just want to ask, how do we apply those various things that you've gone through, that number one, and we'll do that in a moment. Number two, we speak of reforming the delivery system, and most of the time you start with fee-for-service. When you're talking about reforming the system, you talk about what do you do for fee-for-service, and I think we're at a stage where most people think we shouldn't have fee-for-service continue on indefinitely, that there ought to be some substitute, partial or otherwise, system, and I wanted to ask you that. And the third part of it is this. We do have a system that is rather old, that has come back to life now, where we talk about paying the recipient a stipend, and they then get to buy their own insurance. What's the name of that?
In Medicare, it's premium support or a defined contribution instead of defined benefits, just like we did with pensions. Some people call them vouchers,
Can both of you vouchers?
but not in Washington. Yes, sir.
And both of you talk about those three a little
Yeah.
bit, the ones that I just mentioned to you. How do you apply the kinds of things you talked about, Doctor and Shalala? How do you apply them? And my last question is the one you just heard about, the changing of a system. Could you talk about it, please?
You want to start or you want me to start?
Well, why don't you go ahead?
Yeah, well, I think the first is, I think you have to go back to if you're going to look at cost, not access and insurance and equity issues, government is pretty good at collecting money and distributing it, spending. We do our tax system. We do that pretty well. Washington likes, and I like to think when I was here, that we were pretty smart at running things, and we just don't do a good job at running things. The private sector does a better job. Markets do a better job. Markets may not have the equity issues and the fairness issues quite as much, especially in healthcare, because the inequity in knowledge, the doctor has more knowledge than the patient. Now that's changing now that we've got our iPads and iPhones and all as we come through. But the economics, so conceptually, people are going to disagree about what I just said, but I think government has to have that larger framework that addresses the big issues that you showed on your slide, the budgeting, the responsibility, the equity, justice, moral imperatives, and then recognize that human biology, unlike shopping at a grocery store or probably even military spending, the human biology changes so much, so fast. Things like evidence-based medicine are good if you're treating 1,000 patients, but that evidence-based medicine might not work because of your genetic code, 3.2 billion bits of information that make you different than anybody else in the room here. So how can you treat everybody the same coming in? So how do you do it? Number one, I would say, to your first question, I would say take all of that, we're not going to have time to go into details, but align incentives around real value itself. The incentive for the hospital around value, the incentive for the nurse around value, for the doctor around value, for the social worker, and I would include the patient around value. Value means results, means outcomes, means health, means wellness. And our whole system, instead of just saying you get paid $30 every time you see a patient, or $1,000 every time you do a biopsy, or $500 every time you do an MRI, which is traditional fee-for-service, clearly that's not going to work. It's not going to work, and that's why we say leave fee-for-service. But I don't want you to leave fee-for-service, because get paid for service, but the sort of what you're buying should be a package. It could be an episode of illness, 30 days before, 30 days after a heart attack. It could be bundling, where you take 10 doctors and say, you give the heart transplant, here's $100,000, and you figure out how it's going to be distributed. But to do it in Washington, D.C. with 16,000 codes in a fee-for-service system that deal with each of you independently instead of focusing on the heart transplant itself. So to our credit, the government is out there, and we're looking through a demonstration project. But I can tell you the bundling demonstration project that we do here in Washington will take 4 or 5 or 6 years. The private sector is already doing it fast and moving. But the private sector doesn't get fed into the Washington dynamic very, very much as we go through. Question number 2, let's have 1 and 2 fee for service. And I think the premium support issue, which we can come back to, which does apply to sort of Medicare, because that's the big debate in Washington. It has, the premium support is the so-called voucher system, where it's the system of a defined contribution versus a defined benefits. Instead of promising everybody, no matter what happens, we're going to take care, it does give you an actuarial amount of money to what on average works today, and you have to have risk sharing or a risk evaluation in there. And that is, I think, going to be a big debate here, whether or not to move in that direction. If you do move in that direction, it becomes obviously much easier from a budgetary standpoint than promising everybody everything. 50 million people out there with the highest technology, with 6 ways to treat everything. Washington's not going to be able to cap that, and to try to do it through 15,000 codes. Is not going to work.
I agree with Bill. I would take on some other issues, and I'm not sure I'd continue with these demonstrations. The problem is when you do demonstrations, the political system gets involved, and when you select out, I once tried a competitive bidding demonstration. We picked the most conservative areas in the country, particularly the members of Congress that had been yakking us about go out and get competitive bidding. It took them 24 hours to stop us. And so unless you scale up enough,
You
so
were
that
making me
everybody
do all
buys
those
in.
demonstration projects
Yeah.
for you when you were there. No,
But-
yeah, it's interesting.
But unless we scale up, we're not going to get these kinds of changes. The other point I would make is that we need to do the chronic illness issue. That's where a lot of our costs are. So we've got to manage chronic illnesses better. Bill and I have talked at length about the privacy issue in managing chronic illnesses. We almost have to go to third parties because people are afraid that they're going to lose their jobs if they sign up with a managed chronic illness system. So there are a lot of things we can do there. And finally, we've got to do something about standard of care. We've got to get some agreement. We need doctors who are professionals to have a certain kind of flexibility. But boy, if the alternatives range from millions of dollars to thousands of dollars, and I can tell you example after example, I went to get my ankle looked at, and he suggested an MRI, and I said, is that really necessary? And he said, no, you could have an x-ray. Well, the difference in price between the two was dramatic. He just hadn't had anyone that knew the difference in price. So we've got to be very careful about standard of care as well. And only if we bundle payments, I think, or do some of these other kinds of things, will it make a difference. But I do believe that we've got to get it to another stage beyond the demonstration stage to be able to put the politics together.
Byron?
Sam, thank you very much. Well, thank you for the ideas and the thoughts that you have. I was just thinking, I just finished a book called The Measure of a Nation by Howard Friedman, a scientist, a statistician, and a professor at Columbia that devotes the first quarter of the book to healthcare. It's one of the most fascinating discussions I've read about healthcare and the problems and the solutions. So, quick question. I come from a state that has largely had nonprofit healthcare. That's changing now. But in the cities in my state and elsewhere, I see you go down the street and you see on a street corner orthopedic center, cancer center, cardiac center, and more and more morphing towards for-profit centers for very specific kinds of things. And going back to the Atul Gawande piece some long while ago about overutilization, I always wonder, once you put together a for-profit center with that little brick building in that corner, whether you are not absolutely required as an investment decision to drive utilization. And to what extent do you think that increases the cost of healthcare?
Well, it's another example of the fragmentation of healthcare, and we believe that the fragmentation of healthcare, so many specialists, a fragmented delivery system. The fact is, if you get cancer in this country, you need physicians following you forever. If they're following you out of a specialty center, there's a whole different cost than if they're following you out of an integrated healthcare delivery center. But that's part of the fragmentation. The reason those places exist is because the payment system is designed to reinforce them and to produce margins there as opposed to a more integrated system.
All right, it's a good question. It's a big question, and I think that it kind of comes back to like government versus non-government. We don't have a socialized system. All this debate, socialized system versus non. You know, we're a private system. All these Medicare dollars go through sort of private system, private delivery system. Except for the Veterans Administration, we don't own hospitals. We don't own doctors. Even all our Medicare spending. Well, I'm going to finish on this, the spending. I'll come back to the profit. But right now, about 50% of the healthcare dollar does go through government. But that doesn't mean we're a socialized system, because that money goes through government, but it was delivered actually through a private system. Before about 1960, when healthcare, instead of being 18% of the GDP, was down around 4% of GDP, aging wasn't an issue, obesity wasn't an issue, technology, we didn't have technology. My dad had a few pills, but didn't have 25 pills. It was mainly an aspirin that he could do back in even 1960 for cardiac surgery. We didn't have all of these options, these alternatives. You could kind of get by, and the sort of not having a bottom line, forget the word, you can just say profit, you can say efficiency, you can say market driven. And then long about 1965 or 1970, it got to be healthcare costs started going up, allocation of resources, third-party reimbursement. We had Medicare, Medicaid come in. And then all of a sudden, healthcare became a big business. And with that, who runs businesses well? Government, nonprofit, institution. Basically, you can't go out and get good managers. You can't go out and get good accountants. You can get somebody volunteering some time after hours, but to think about life and death decisions, high technology, sophisticated allocation, 68 cost centers in a single clinic coming in, a nonprofit doing that well. It just didn't. And therefore, you had an industry that really exploded by bringing in professional accountants and professional managers and people who, doctors want to practice medicine. They don't want to be back there running a small business. They used to. Now we're coming back to it, as you pointed out. And therefore, you have this explosion. And with that, you have inefficiencies as you do in any market. But the competition of the for-profit motive in healthcare through the 60s and 70s and 80s all of a sudden meant the nonprofit, inefficient hospitals, and I'll use hospitals as an example, or clinics simply couldn't stay in business without hiring professional management, without that sort of competition. So hospitals, you may have had just a narrow 10% for-profit, some not very good and some good, but as they professionalize the other 90% of the nonprofit. So every one of your nonprofit hospitals in your state are today professionally run by professionals without the competition, without the marketplace there or not there. And you pull the CEO of any of your hospitals aside, he says, I'm in the profit-making business. You can't run it without that sort of bottom line. Now the question needs to be applied is, where's the innovation going to be? To think that the acute care model of a hospital, of a delivery system, is going to work in a field of understanding the personalization of healthcare. The expense of healthcare, it's just not. It's going to move to the outpatient. Where we've innovated in imaging, we've innovated in drugs, we've innovated in patents, we've innovated with PhDs and Nobel laureates or Nobel Prize winners in science. Where we have failed in America is innovation in our delivery system. We are still an acute care model, little emphasis on wellness, little on prevention. Wait till you get sick and we can cure it with a heart transplant instead of prevention up front. Now, why is that? And why do we have a problem with Medicare, unlike London where I was, or England where I was yesterday, is because the government there is taking care of you from the time you were born to the time that you die, And therefore, they can put more money into primary care earlier on or into prevention and wellness because they know 30 to 40 years later, the payback is going to be there. And our insurance companies here, where everybody's switching every 2 to 3 years, has very little incentive, unless you regulate it, to come in and invest early on. And so our Medicare program has to be smart on prevention and wellness. Is that too late when we come back to chronic disease? You develop your heart failure before you're 65 in many cases, so we're going to have to work it into our private insurance system much, much earlier. I think most of the innovation today, and this is going to answer your question pretty directly, is coming from the for-profit, not just for-profit sector, but the competition in markets that were originally driven by the for-profit sector. That is where they have a bottom line, and a nonprofit group does not, and that competition is set up. If you look at how you start focusing on chronic disease management today, University of Miami can probably do a pretty good job, and Geisinger, everybody focuses on Geisinger, Mayo, Mass General, they can do it, but that's a little tiny. Of this $2.7 trillion, that's $1 trillion. What about the other $2.6 trillion that are out there? And most of that innovation, you got to be fast. You do have to have access to capital. You have to be measured. You have to play by the rules. And that's where I think most of the innovation is going to come from.
I agree with that, but fundamentally, our system is designed to reward procedure. We make our money on hospital beds. I mean, we're waiting for the outpatient to start making money for us, but we're making our money on the hospital beds, on the institutional care, and on doing more for the patient. As long as that system continues to exist, you can give us all the IT in the world. Our incentive is to get our margins out of doing more to the patient.
I'm going to have to, just because we've got another panel, this is fascinating, we could go on forever, but Evan, I'm going to give you the last question for this panel, and then our two bills, I will let you ask the questions to the second panel.
Thank you, Sam. I'll be real brief here. My formative experience in public life was as a governor. And so I've got a healthy appreciation for the role that states play as sort of laboratories of experimentation. And Bill, you were just talking about your familiarity with other systems. So my question is very simply for the two of you. Looking at the 50 states, is there one out there that's trying some good things that we ought to look at as possibly a model? Or how about the other countries? Is there one you think is getting it more right than not right that we might look to as possibly for some guidance because they've actually been doing these things?
Well, I think lots of the states are doing something that's interesting and innovative, whether it's whether it's trying to get control of Medicaid costs by using a combination of IT and other healthcare providers to manage the process better. I mean, there are lots of things going on out there. Each state has to put together its own pieces and look where its costs are. Here's what I can tell you. When states have transferred their Medicaid systems to the private sector, those private sector companies are getting pretty good margins. That tells us something about the management of the Medicaid system. Now, are they giving less care as a result of that? In some cases they are, in some cases they aren't. So Bill's fundamental point about we've got to learn how to measure outcomes value. So no matter what the organization is, whether we do it through the private sector or manage it ourselves, we've got to make sure that we're getting quality for our money. But I think that there are a number of states, including Indiana and Florida, that are trying some different kinds of things. There are a number of states that are trying things in mental health, for example, Senator Domenici. So there's a lot of experimentation going on. One of the things we have to do is make sure we don't restrain the secretary from doing more with waivers and trying out new things. The Democrats are as bad as the Republicans on this, from this point of view. They're so worried that she's going to give away the store for the dual eligibles, the Medicaid, Medicare types, and the Republicans have similar worries about competitive pricing and some other kinds of things. So I think we need to let the secretary work with the governors and work through some of these alternatives so that we continue to experiment at that level, but we've got to learn how to measure outcomes at the same time.
Yeah, I agree. I love the states, and nobody's smart enough to lick this. It partly goes back to human biology. We're just constantly we're just evolving so quickly in science. We're learning to treat The cost of healthcare is so big because we do a lot of over-treatment, this fee-for-service more you do, but that's, again, an oversimplification. So I don't want Washington to think if we get rid of fee-for-service, everything's going to be okay. You know, we can go into that, and I'll participate in those debates. But it's very important to do because human nature is, that's the way you're getting paid. You just do more of it. But we have this overuse and we have this underuse, which we got to address, and it's prevention and it's wellness and it's obesity. It's catching this stuff before it becomes a heart transplant, which I love doing, but I don't want to do that many. And then there's the misuse, which is just the misallocation, the waste, the 20 to 30%. We're just not treating appropriately with the medicines and with the technology that is there. The delivery system, if Washington comes in and basically says we can deliver health care well, we know the system, it's just false. We can't, but a lot of people like to think we can. And therefore, the Affordable Care Act did this. It basically said, we don't have the answer. We don't want a socialized system. We don't want to own hospitals and own doctors and all that. And it pushes a lot down to the states. These state exchanges that you can either like them or not, but what it means, we're going to have 50 laboratories out there taking state-of-the-art. The states are more nimble than the federal government because the governors can come in and just close things down the next day, or they can open them up. And with that, and so we're going to have 50 laboratories out there that are going to have markets where a huge number of people will be able to go in and get information about their health care plan, about outcomes, about what it costs, about transparency, and that's what markets are. Where is that going to come from? Not the federal government, but it's going to come from 50 states out there and 50 governors. And all healthcare is, in essence, local, but this intermediate government level. And one last thing, just because dual eligibles. Washington wants to treat everybody the same. You just can't do it. Can't 300 million people with the same policy. You just can't do it. If we don't have the money to do it, it's too expensive to do it. 5% of people, or 1 out of 20 people, so there are probably 5 people in here, maybe 6 people in here, are responsible for 60% of all healthcare spending. These 6 people right here. The secret to all of this, I don't necessarily know what it takes, but say 7 people in here are responsible for, say, for 50% of all healthcare spending in the country. So if I want to address your line, all I need to do is find those 7 people in this room. And basically, I can manage you state of the art. I'm going to spend full time on you. Instead of trying to spend time on everybody, I can forget about everybody else if I can identify these 7 people. How do we do it? It can be done. Just one thing, there is 1 billion patient years of medical records, clinical claims data that is in Medicare. Say 30 million people times 50 years, or however long it's been, so whatever that comes to. But there's 1 billion patient years of information. Why can't, not we anymore, but why can't the government come in and take that data and look at it to be able to predict who these 6 or 7 people are, seniors? And if we focus on those 7 people, you can forget about all this other stuff and the 16,000 codes and all of that. Conceptually, that's the sort of thinking that we can do today that we couldn't do when Donna was in charge or when I was majority leader 6 years ago, because we didn't have the know-how. We didn't have the analytics. We didn't have this stuff. And if the federal government basically said, let's take that data, let's analyze it, let's focus, let's target, all these other problems kind of go away that we're trying to micromanage.
And Senator, I think we're saying the states could do a lot. They also could do tort reform, because that's a state-based issue, and they certainly can do something about scope of practice. So as we talk about who does what, we've got to hold the states accountable at the same time, because they've got a big stake in this, as the Senator.
I want to thank both of you. Fascinating discussion. A lot of creativity here. Good ideas. Thank you. Our next 2 witnesses, if they would come up, John Taylor and Alice Rivlin. I'm going to give you both, again, a very brief introduction. Technology. Alice and John, thank you both for being here. Let me, I'm not sure who's going to go first. I'll leave it up to you all. But Dr. John B. Taylor is the Mary and Robert Raymond Professor of Economics at Stanford University and a George P. Schultz Senior Fellow in Economics at the Hoover Institute. He is Director of the Stanford Introductory Economics Center. John's academic fields of expertise are macroeconomics, monetary economics, and international economics. John is well known for his research on the foundations of modern monetary theory and policy, which has been utilized by central banks and financial market analysts around the world. From 2001 to 2005, he served as Undersecretary of Treasury for International Affairs. John also served as a member of President George H.W. Bush's Council on Economic Advisors and as a senior economist on President Ford's and President Carter's Council of Economic Advisors. John was recently awarded the Manhattan Institute's prestigious Hayek Prize for his new book, First Principles, 5 Keys to Restoring America's Prosperity. John, we're delighted to have you here. And Alice Revlin, this is your second appearance, and Alice has helped us plan this series, which we are very grateful for. Dr. Revlin is a senior fellow in the Economic Studies program at Brookings and a visiting professor at the Public Policy Institute of Georgetown University. Alice served as vice chair of the Federal Reserve Board, 1996 to 99. She was director of the White House Office of Management and Budget in the first Clinton administration. Alice was the founding director of the Congressional Budget Office, 1975 to 1983. She was named one of the greatest public servants of the last 25 years by the Council for Excellence in Government in 2008, and I certainly concur with that judgment. In February 2010, Dr. Rivlin was named by President Obama to the Commission on Fiscal Responsibility and Reform, the Simpson-Bowles Commission. She also co-chaired with former Senator Pete Domenici, our co-chair here for these forums, the Bipartisan Policy Center's Task Force on Debt Reduction. Again, I could go on and on, but John and Alice, we're delighted to have you.
Thank you very much, Senator. Thanks.
John, before you proceed, might I say, Alice, you understand that I could have introduced you had I really worked on him, but he wanted to keep the symmetry, and I said, go ahead. Yeah, I don't know anything about Alice, Dr. Rivlin, anyway.
Thank you very much, Senator, both senators, for all you're doing and for other people here. Appreciate you all coming, and it's a pleasure and honor to be here on the panel with Alice Rivlin. I am going to refer to a few charts. I remember in the first panel, I wrote this down, Bob Rudman says that we must be sure that the substantive effects are fully understood of what we're talking about, and sometimes the best way to do that is with a few charts. So this chart to me is one that really we ought to just think about as we think about containing spending. It's a chart of total debt held by the public back to the beginning of our country. And you can see the blue line is our history. And we have had ups and downs, largely related to war. Most of those ups and downs are completely insignificant compared to what we're about to go through. If you look way at the top right-hand part of that chart, you see the projection that CBO made of this debt-to-GDP ratio back in 2009. Well, they do this every summer, and they continue to do it. And unfortunately, there has been absolutely no improvement in that line. The only thing that CBO has done in their analysis is stopped the explosion by saying we can't go above 250% anymore. So the red line, their most recent projection, just stops it. Says they don't want to guess the look at the bad news. Well, that's obviously not the way to end this. This growing debt is the problem at the focus of this whole initiative and forum, but it is intimately related to another problem in our country, and that is our very slow growth of the economy. We've got a combination of slow economic growth and exploding deficit and debt, and they're related. So if you could take a look at this next chart, it illustrates this. It's a busy chart, but it really represents the problem with growth in our economy. This doesn't go back to the founding of the country. It only goes back to 2007 on the horizontal axis, and it plots real GDP, the best measure we have for how we're doing. And if you look there at the bottom left, you see that drop-off in the blue line. That's real GDP. That was the recession. Unfortunately, we're not recovering from that recession. The growth is very, very low. It's not even catching up to the lines that CBO says we should be able to get to. So growth is very low. We need a recovery if you'd like to get to that trend. And we also need to grow more rapidly in the future. And that's what those projections of CBO now and what they could be if we just raise growth 0.5% or even 1%. Now, our growth in the debt is one of the reasons we're not recovering. Even now, it is important to think about our children's future. But it's right now, us, our children as they're existing today, our grandchildren as they're existing today. This low economic growth is causing high unemployment, and the high debt is one of the reasons for that. So they're intimately related. Senator Domenici's chart showed at the beginning the main reason for the explosion of the debt is spending. And the main reason for the increase in spending is the increase in healthcare spending by the federal government. That's shown in chart 3. If you look at that briefly, it doesn't say anything more than Senator Domenici's chart showed, but you can see as you go into the future here and look at healthcare and Social Security as a share of GDP, what's driving this is healthcare. And so we need to contain spending, and we need to contain healthcare spending, and the simplest way to think about it is to keep the growth, roughly speaking, at GDP. That may sound like a big picture way to think about it, but that's ultimately what we have to do, and there's different ways to do that. So if you could look at the next chart with me, this is, to me, the most important chart to look at, to understand what's going on, to really fully understand the difficulty of this whole deal we're in. This is simply the ratio of federal spending to GDP. GDP is a good measure of our capability of supporting government spending, so it's a natural denominator. It goes only back to 2000, and it's projected out to 2020. The blue line is our history. It shows, to me, an incredible surge in federal spending as a share of our GDP. Back in 2000, it was 18.2% of GDP. In 2007, 19.7% of GDP. It had got up there to 25% in the recession and has come down to just about 24. And then you go beyond the blue line, you see really what we're debating about here. This is really the whole nature of where we are going forward. And I've drawn in a few lines here to illustrate. The top line, the red line, is the proposal of the administration for the budget last year, February 2011. So as drawn, it really didn't do very much to deal with this, as I see, spending problem, spending binge. The sort of a teal-covered line is labeled Simpson-Bowles. That's really what Simpson-Bowles proposed as a share of GDP. So it's substantially lower than what the administration proposed, about the same time. That was December 2010. The administration was February 2011. The green line is my proposal. This came from an op-ed that George Shultz, my colleague, former Treasury Secretary, knows a lot about these things. Gary Becker, Nobel Prize winner, we drew this line. We called it a pro-growth budget because it really, it seems to me, gets the opportunity we have to get rid of this debt explosion. And then finally, if you look at the black line right below the red line, that's where we are now. That's CBO. That's their projection, excluding, by the way, the sequester. It's basically just the projection of what they think will happen, their so-called alternative fiscal scenario. So if you look at this chart with me, I think there's several very important points to draw, and I'll just conclude with those. Number one, the problem here is really just undoing something that's had happened very recently. If you'd like to think about the goal of the red line, the green line, the goal of the green line, all that does is bring us back to where we were in 2007. That shouldn't be so hard. If you were talking to a family that their debt was in terrible shape, and all they had to do is get their spending back to where it was before they ran into the debt problems, and especially if it was only a few years ago when times really weren't so bad, they may say, hey, this is good news. I can make this adjustment relatively easy. That seems to me what's attractive about simply benchmarking back to where you were recently. Second thing is this is a very gradual decline. In fact, all of those are pretty gradual, even the green one. This shouldn't be disruptive to the economy. In fact, simulations of models that we've done show this actually will increase economic growth. It's not like an austerity type of concern that you should be worried about. I think it's very important. It's a very gradual decline, much more gradual than the rapid increase. Third thing I would observe, and this is Very important point. All of these ideas require that we contain healthcare spending to have it grow not much more than GDP. In fact, I don't think there's much disagreement about that idea going down the road. The disagreement is how you do it. And we heard some of the discussion, Senator Frist, and describing the premium support and overall totals. If you look at the proposals of the administration, the proposals of the House, proposals in this campaign, all of them have healthcare spending, Medicare spending in particular, being contained substantially. The difference is, how do you do it? Do you do it with a premium support, which to me as an economist is decentralizing the decisions to the doctors, to the patients, to the insurance companies, where prices and quantities and qualities are determined there, or do you have it decided at the center? And whatever you want to do it, don't think of one as more draconian than the other. And the last thing I'll mention is all of these, while it looks bad, they're coming down. Nothing's coming down. All of these are increases in total spending. So if you just look at the last chart, chart 5, that's just taking those shares of GDP numbers and translating them back into the actual dollars that must be spent and appropriated or part of the entitlement system. And they're all going up in nominal terms. Even the green line is going up in nominal terms for this period as the shares are coming down. So this seems to me something that all of these are doable. They all deal with this important problem. They all deal with the health care in one way or the other. And it seems to me that's the thing that we should be focusing on. Thank you very much.
Thank you very much, John. Alice?
Thank you, Mr. Chairman. I'm not going to give you any more charts because I think John has done it. I don't have anything to add to that set of charts. I think that having me and John Taylor together is an interesting illustration of where economists where economists differ on some things, but more especially where they do not. There is a lot of mythology about our profession, and people say, economists never agree. They disagree even on the facts and even more on the projections. I don't think that's really true with respect to this particular problem. And we have a good example right here. And I don't have any quarrel with the charts that John has put up or the major points that they illustrate. We're agreed that the current budget path is unsustainable, that the spending drivers are Medicare and Medicaid and other health care, and to a lesser extent, Social Security. And we know the reasons for that, the demography, the increasing number of seniors, and the rising cost of health care. We know that for those reasons, federal spending is on track to grow faster than the economy can grow and faster than revenues will grow at any set of tax rate. And that creates a widening wedge of borrowing that will drive up the debt to GDP ratio, will eventually drive it off the charts, although the CBO has decided not to let it do that. That will make it more expensive for our country to borrow and eventually impossible to borrow the amounts that we will need to. It will mean spikes in interest rates, slower growth, and perhaps a really prolonged recession or depression. And we all agree that growth is the key. We must have higher growth to regain prosperity and our leadership in the world. So there's not a lot to argue about in terms of those facts. One big uncertainty is how fast do we have to move? When do we hit a catastrophe or a moment in which we can't put it off any longer? Now, frankly, nobody knows. John and I are among those who say we can't afford to wait because it'll be too late if we find out. We better get a move on. Some of you may have seen Paul Krugman's piece in today's New York Times, and Paul is an example of a few economists, I don't think very many actually, who think we have a lot more time. And I think I could speak for John saying, don't count on it. There are bigger issues on which we may differ. One is how fast to move back to a sustainable track, and the other is what is the mix of spending and revenue changes that we need to get there. Now, John's not an extremist. He's not a big anti-government person or a libertarian, but he does believe strongly in limited government and predictable rules. He believes limited government and predictable rules are much better for growth than larger government and more intervention, right? Now, I'm not an extremist either, but I would tend to move a little slower to the sustainable track than I think John would. Because I think the principal cause of the slow recovery is the depth and severity of the recession caused by the cataclysmic financial and housing market crash. We shouldn't have had that, but we did, and we're in a very deep hole. So I would favor more actions to help people get back on their feet than I suspect John would. And that also leads me to believe that going over the fiscal cliff, which some people are saying, well, let's just do it, would throw the economy into a new downturn. So I would favor getting back on a fiscally sustainable track fairly slowly, but that doesn't mean putting it off like Paul Krugman would. It means legislate now, but legislate it in a way that means we get back on the track fairly slowly. The bigger difference, I think, is over the role of government. I suspect I would favor a stronger safety net and a somewhat more activist government than John would. And that reflects the differences in the larger population. That difference affects the mix of spending and revenue changes that are desirable to get onto a sustainable track. It turns on how we cope with this avalanche tsunami, as Pete called it, of seniors that are affecting our budget. John, in his very excellent book that I commend to you, suggests that maybe going back to the 19.5% approximately of GDP that we were spending in 2007 could be considered some kind of a norm, because that was before the financial crash and the Great Recession. But I would point out that whatever past year we take as a norm, or better, whatever collection of services we think ought to be provided by the government, providing that same services is probably going to take more spending in the future than it took in 2007 or in some other pre-crisis year, just because of what we've been talking about. We will be dealing with this much larger number of seniors, more than half again very quickly, and almost twice as many in Social Security and Medicare in 3 decades than we have now. I doubt that we can or that we should cut back on the rest of government enough to accommodate that big a demographic shift. If we did, it would risk reducing the investments in education and science and infrastructure that we need for growth. Now, those are differences, and they're widely reflected in the public at large. But let me come back to what we agree on. I think we could agree that whatever the size or role of government we think is appropriate, we need to pay for it. And that means getting back on this track that will come close to balancing the budget, or at least will allow us to reduce the ratio of the debt to our economy by not having a deficit that is larger than the rate of growth of the economy. And secondly, I think we could agree that whatever we decide government ought to do, we need to do it efficiently and in a way that interferes as little as possible with growth. And that's an argument for a more pro-growth health system and a more pro-growth tax system. So let me just finish with a couple of specifics. First, we do need to put Social Security back on a firm foundation for the future. It is really stupid to wait to do that. We need to assure people currently in the labor force and entering into it that Social Security will be there for them and they can plan around it. I am fully with John on predictability on this thing. Now, here we may have some different emphasis across the population, again, over what ratio of spending cut and revenue increase would be appropriate. But a bipartisan compromise means some of each. You can raise the retirement age a little bit far in the future. You can index it to longevity, as Pete and I did in our report, rather than raising the age. You can raise the taxable wage base gradually, improve the measure of the CPI. None of these changes need be very large, but we ought to do them now and just get on with it. And finally, we need to use, as we've been talking about, the federal health programs to move the whole health system toward greater efficiency, less waste, more incentives linked to outcomes and value, as the previous panel said, rather than to higher volumes of services. The election has escalated the rhetoric and made the differences seem, I think, much bigger than they really are. Actually, I suspect we're quite close to a workable set of compromises here. With respect to Medicare, we've talked about the premium support model and the Affordable Care Act model, which is more of discover what works well and what incentives work well and put them in by regulation. Pete and I in our report said, why don't we do both? Keep fee-for-service Medicare for anybody who wants to be in it and keep improving it along the lines that we have talked about, but offer people a choice as well. That seems to me a good compromise. Whatever we do here, the differences are not so great. We are not arguing about whether incentives should be for value rather than quantity. And we're not even arguing, as John just pointed out, about the rate of growth. Everybody thinks can't grow the Medicare spending or the whole healthcare system much faster than the GDP. So the bottom line is the differences are real across the political spectrum, but compromise is essential. And the one thing we can't afford is gridlock. We can't afford to do nothing because everything gets worse if we do. Thank you.
Thank you, Alice and John, for very compelling testimony. I wish we could put you two in a room and feed you well until you, or maybe not feed you so well until you came to an agreement and just pronounce it as being the answer. But let me just ask one question. We got the fiscal cliff coming up. I think both of you agree that that would be a disaster. If the lame duck session were to move in a direction of substituting Domenici-Rivlin, legislatively drawn, or Simpson-Bowles, or some combination of those two, instead of kicking the can down the road, change cans and have Domenici-Rivlin or Simpson-Bowles as the new can, so that they have 6 months or 3 months or whatever to change it if they want to. But if we go over the cliff, we go over to a softer landing, not a disaster. If that kind of proposal were to come up in the lame duck, what would you, I'll ask both of you, what would you think about it as an alternative to where we are now? A new default position.
We certainly need a better default position than we had in the fiscal cliff. We want one that will put us back on a track to sustainability, and that whatever you might think about this particular solution is a lot better than doing nothing. And that's not true of the fiscal cliff. It's probably worse than doing nothing for, at least for a little while, because it could throw us into recession right away. So I think that's a reasonable idea. Not going to be an easy idea to get across to your former colleagues, however.
I would say one of the problems with just doing, say, Simpson-Bowles as currently as written down back in December 2010 is it actually also has a very large immediate tax increase if you take it literally. And so, in fact, it's not much different than the fiscal cliff tax increase in terms of percentage of GDP. So that would have to be looked at very carefully, I think, on the tax side. On the spending side, actually, as in my charts, illustrate, I think, a very interesting coincidence, perhaps, and that is for fiscal year 2013, the Simpson-Bowles spending as a share of GDP is actually very close to what the House budget has for 2013. It's very close to the green line in my chart. It may be something people could agree on for 2013. And that's not a small item, because the 2013 budget it's already past due, of course, but that's got to be dealt with in the lame duck. And so I would think that may be a possibility. Tax reform itself is extraordinarily complex, and it's not something that's going to be decided in a lame duck period. So I could imagine agreeing to, at least until the overall parameters of the 2013 budget, people understand it. They've talked about it. It wouldn't be a surprise to the members. They could, I think, deal with it in the lame duck. And then, in fact, maybe even have the instructions to the committees for the out years follow the same spending line, which is also in my picture. It's actually a flat line. And then in the first 6 months or whatever of the new session after the inauguration, people hammer out the rest of this. They hammer out the tax reform. They hammer out how much of the tax reform will be, if you like, revenue neutral, and how much will generate additional static revenues. So I think that's a possibility. And again, primarily because of this almost coincidence that, as stated back in 2010, Simpson-Bowles is quite close to what I think would work for 2013.
Is Domenici Rivelin have that same revenue feature as Simpson-Bowles in the early years?
No. And I think here we're talking about phasing in, and the phasing that you might find feasible right now is different from what you might have thought of in 2010. So I wouldn't pin that tax number or the spending number on Simpson-Bowles. They both plans are in the process of being updated. But actually, in our plan, Pete and I thought we needed some more stimulus up front. I still think that we need some too. We were proposing a full year payroll tax cut in the first year of the plan as a sort of indicator that you don't want to go to too austere a budget right away. And it just seems to me the European experience has proved that. I think John will probably argue with that.
Bill Brock.
There are a lot of people that would argue the part of the problem we have today is the degree of uncertainty that affects business decisions, investments, and so forth. Regulatory questions, tax questions, spending questions. And I think it's fair to say that unless we have some, at least additional certainty about where government policy might lead, that may continue. The worry I have, Mr. Taylor, is that if we deal with the spending side without any tangible commitments on the tax side, maybe just in gross revenue numbers or whatever it is, that you might not address that certainty. And I guess the worry that I have is that we punt on the hard stuff. And I'll just give you one immediate example. We're going to have a pretty good debate on whether or not to extend the payroll tax. We're worried about Social Security, but we're reducing the revenue stream to fund it. that's palpably dishonest. And so we keep doing these on a temporary basis, and we postpone the action because it's hard to do what you want to do or believe you should do. I'm not quite sure I understand how to deal with that conundrum, but I think it's very real at the moment.
So I certainly agree about the uncertainty as a drag right now on the economy. There's measures of it, and the debt explosion is part of that. People don't see how it's going to be resolved. They worry about massive tax increases or even a fiscal crisis, as Alice is referring to it. And there are other elements. I actually think the fiscal cliff is itself of course, didn't come from outer space. It was created by government. And in a way, it's the same kind of policy uncertainty that we've been getting more and more of. More and more provisions in the tax code are expiring each year, and it just so happened these are all coming on the same date so people can see it, but it's been happening for a while. In answer to your question, what's the best way to create more uncertainty in this difficult time, say just in the lame duck period? I think it's something that most important is to have something that's doable. What's quite striking to me about when you look at the progress, and there has been progress in the last couple years at least, for the budget proposed in February 2011 in my chart was way up there, and it's now down. Not a substantial amount. It's on, and the Simpson-Bowles would bring it down further. So would the sequestration, but we don't want to do that. That's so damaging. So it seems to me that if you can give the confidence that we're bringing those down, and I think there's not much disagreement that those should come down. It's a measure of how far should you stop at Simpson-Bowles, or should you continue to the line that I drew, and which is obviously an alternative on the table. And it seems to me if you can get it closer, you've reduced a lot of the uncertainty, and then the debate is going to be, and this would be a negotiation, which should take after the election, which is how much of that is going to be revenue and how much is going to be spending. But you've narrowed the gap substantially, and I think that's what I would.
I certainly agree that the uncertainty is a real problem, but I think that is why we need this grand bargain. We need to have a bipartisan solution that can't be overturned. We're not going to have elections saying, do it this way, oh, no, do it that way. We need a bipartisan compromise, and the two bipartisan groups that I served on came to the conclusion very early that you can't do the closing of the gap all on the spending side or all on the revenue side. You have to have some of each, and I think that's the essence of a bipartisan compromise. There is a reason why the Simpson-Bowles line on John's chart was somewhere between the president's budget and his own, and it's because it was a compromise, exactly that.
Thank you. Bill Frenzel?
You've spelled out different ways we can get to heaven on this budget problem of ours. Do both of you think that we can stabilize the debt within 10 years? And if so, what happens thereafter? What's the course for the country at that time? And should that be a part of the bargain now?
I think we can stabilize the debt within 10 years if we make these changes. There's no question about that. After that, I think it's reasonable to try to make sure the debt doesn't pick up again. And we have the confidence that we're going to keep our debt to GDP ratio 40% or whatever we want it to be, 40, 50%. And we have been pretty successful on that since World War II, until recently. And so it seems to me that's a doable proposition, but it can't be complacent about it. It's got to be a constant focus, and obviously it has to, at some point, has to be agreed to by the Congress. How are you going to do it?
I agree. I think we can stabilize probably within less than 10 years if we do the things we're talking about on this panel. And we're probably getting some help. This goes back to the healthcare discussion. we're getting some help from what's going on out there in the health sector already. Because it does appear that the growth of healthcare costs is slowing, and partly because people are doing sensible things, both publicly and privately, and in many states. So I don't think that's impossible, but we do have to make sure that we don't let the debt grow faster than the GDP. It's got to grow slower.
Whether there needs to be some sort of special discipline after the stabilization of the debt so that we have a relatively balanced budget over a cycle.
Well, this has to do with budget rules and various kinds of constraints on spending. I think that certainly the recent experience shows that we have trouble keeping spending under control. So I would like to see some kind of, and as Alice said, I'm a real proponent of rules and predictability. So if there was some way to enforce, I would say on the spending side, there's other ways to do it. And I would say on the spending side is enforce some kind of a long-term goal of what you'd like the federal government to be spending as a share of GDP. I focus on the share of GDP so much. I know it's already gets into the arithmetic, which is confusing to people, but it seems to me that's the way to think about this. And I would encourage somehow you do that.
I think the essence of the challenge is how do you bring the entitlements into the budgeting process? And they're not now. Someone referred to automatic pilot. The budget is the appropriations, the discretionary spending is not the source of our problem. We know how to control that. The problem is mandatory or entitlement spending, which has been outside the regular budgetary process. It's got to be inside. Now, that doesn't mean that you review Social Security and Medicare every year, but you've got to set a sustainable track and then review it periodically, like every 5 years. The Congress comes back to this, says, have we gotten off the track, and what do we want to do about it?
Pete?
Well, obviously, we're finishing our event this afternoon, and I don't want to let the occasion pass without thanking you for putting this idea together and asking me to help, and for all those that joined. I think in a short period of time, we were able to amass a terrific record that, in essence, shows less disagreements for the biggest problem America has ever had outside of the Second World War. It shows less disagreements among the economists and among the experts than almost any major issue we've had. Today we have two economists. We'll put you in as an economist, Alice. You've been all kind of things, and we know where John fits. I mean, you have differences, but look at, for the biggest problem we've got, the differences could obviously be solved. If he said the two of you go solve them, and how much time do you want? And you said, are you serious? We can do anything we want with the code? And we said, yes. You'd probably say, give us a week. And I'm just setting what I think. A week and some good staff. We heard the economists, one of whom last week, one of whom represents the immediate, this president, who left him about a year and a half ago, and the other economist that was there with him was
Larry Summers and Marty Feldstein.
Marty Feldstein is known as the Republican from Harvard on taxes, and by the time they were finished, there is no question they could have agreed on a revenue package without question, the two of them.
That's right.
Take them a little bit of time, because one thinks we can cap them, the other one thinks we ought to go ahead and do away with most of the tax expenditures. Look at the issue of health care. We've had two witnesses from very different parties, very different issues, one would think, different sides and positions. They would sit down, if given the time and the opportunity, and solve the Medicare problem in a couple of weeks and present it to somebody based upon the fact that It isn't the size of the problem. The fact of the matter is they know it must be solved, and they're close enough together to get it solved. I've been in the Senate on issues that were much more debatable than this, and they were small issues. Here we've got the biggest fiscal issue, and the disagreements are the smallest are less than I ever anticipated we would be on this particular day in the evolution of these issues. Let me just make sure that I've got this straight from both of you. It becomes quite obvious that it isn't enough to talk about, do you need revenues? Are you going to get revenues? Do you need entitlements reformed, not cut, but reformed, and then reformed in the out years, not tomorrow, not next week, not even next year. Maybe 10 years from now they start to change in terms of what you get. But the issue that overwhelms all of this is that the American economy is not growing, and it doesn't make too much sense to, let's strike that. It doesn't seem to me to be a valid approach to close these sessions without asking the two of you, am I correct when I assume that the debt and its continued growth in relationship to our gross domestic product is an inhibitor to growth in the American economy? And if so, is it a major inhibitor? And if that answer is yes, then obviously when we speak of debt, we can simultaneously speak of growth. Can't have this much debt and it growing this fast if you want the economy to grow. But that was my assessment after a certain stipulation. What would you say about that, John?
Well, I would agree. It's a detriment to growth, the growing debt, and that's why it's so important to solve it. We want to get growth faster now. We want to get growth faster for our children and grandchildren, but right now. And I think we can do that in this gradual way, and it would be a benefit to the economy. It would remove some of this uncertainty. It would create more opportunity for the private sector. So I would start with it right now.
Well, John, let me tell you why I asked the question. We're just 40-some days away from an election. And I'm not going to get myself into this campaign with the statement I'm going to make next. But it's pretty obvious to me that we hear more talk about who creates jobs. And I would assume growth creates jobs. I didn't add that. Is that correct? He's nodding, so we can add that to my assessment. You get jobs from growth. Without growth, you don't get jobs. And Alice, you agree with that? Is that correct? Now, the point of it is, if that's the case, and we're out here running for president, and we're talking all the time about who's creating jobs, but nobody's talking about the budget, and we're assuming the budget's one of the most important things that will bring us jobs or lose us jobs, as the case may be. Alice, would you address my issues and see if I was on base or not, in your opinion?
Oh, I agree with you. I think that the campaign so far has been really not focused on the big substantive issues. There have been a lot of words about jobs and debt, but what we need is a serious debate between the candidates as what would you actually do to create jobs, and what would you do to stabilize the debt and bring it down. And we have not had serious addressing of those two issues, and we should.
Thank you very much, Pete. Evan, let me give you the last question or word, whatever the case may be.
Well, thank you both again. Just very quickly, it seems to me we've been fortunate in one respect, and that is that interest rates have been historically very, very low at a time when our debt burden has been increasing. At some point, the interest rate picture is likely to change when we have a resumption of growth or the Fed starts unwinding the programs that they've put into place or what have you. If you could just take a minute each and just share with us how much bigger the challenge will be if we wait until interest rates start going up and servicing our debt becomes that much heavier. Conversely, if we act more quickly, let's say in the next 6 months or so, to put into place a long-term path to dealing with this, what might be the dampening effect in the future when interest rates do start going? How much would that ameliorate the eventual rise of interest rates if we have a long-term strategy in place for getting the deficit under control?
Very briefly, I think it would be an enormous benefit in terms of the very high risks right now of rapidly rising rates down the road with this gigantic debt. And also remember, the Fed has purchased a lot of the debt already, and that will have to go back out into the system. To me, it's a major risk and uncertainty in the future, and it's another reason why if we deal with this now, we'll reduce, that risk is still going to be there, but we can reduce it substantially, and I think that should be added to the reasons. Thank you.
You started by saying, fortunately, we have been able to borrow all this money at low interest rates. I would suggest that it's been a very mixed blessing. Countries that can't borrow at such low rates are forced into more discipline than we have been forced into. But clearly, we are now carrying a very large debt at a lower percent of our federal budget devoted to debt service than we had even, I believe, at the beginning of the 90s, because the interest rates were higher. If we were to go back to those higher interest rates, remember, we could go much higher than they were even then, it would mean that we were devoting a very large proportion of our revenue to servicing the debt, because you got to pay that off the top. And then you do whatever the government is supposed to do. So we were actually worried about that at the beginning of the Clinton administration. It was one of the reasons that Clinton focused so heavily on the debt reduction, with the help of a Republican Congress, I should say here, eventually, not in the first 2 years. We were genuinely worried that the debt service was going to explode, meaning that the debt, you'd have to raise taxes just to pay the interest on the debt. Now, we're not there now because the interest rates are so low, but we could get back to that.
Okay, to my fellow colleagues, thank you very much for participating. We will continue to work on this issue. To CSIS, thank you again. Concord Coalition and Bob and your group, thank you. And Pete, to the Bipartisan Policy Center. To our witnesses here, we are very grateful to you. We're going to continue to work on this. We're going to have some kind of report in the next few weeks. There's a larger effort going on that we will be part of called Fix the Debt. That's going to be very active after the election, the post the lame duck session and so forth, and thereafter. So this is going to be a continuing challenge. Alice, really grateful to you. Terrific. John, thank you so much. We appreciate it, and all of your team out at Stanford does tremendous work. I've been a first-hand witness to that, so it's a great pleasure to be here, and we appreciate Hoover being part of this effort. So thanks to you all.